everyone. Good morning, good afternoon, good evening, depending on where you're tuning in from. It's good to see everyone here, and even as people join in, I think in the interest of time and respecting those that were able to actually join in time, we'll just get started. And the others will join as they get the time and chance to do so. So I hope you can hear me. Yamanya, kindly give a thumbs up if I'm loud and clear. Um, yes, no, or anyone else? Ryan, can you hear me?
Loud and clear.
Yes, I do.
Great. Okay, good stuff. Okay, so
Do you see
thank
me
you.
now? Do you hear me? All things good?
Yeah, we hear you, Ryan. So give me I will take this opportunity and the pleasure to actually just invite you. But before I do that, perhaps I should just just give a bit of a background on the webinar series that we are conducting, which, as you may have seen, is on strengthening global action against AMR. So we're looking at, from commitments to implementation. This being the second webinar series, now actually delving into it, from paper to actually progress of the actions that we're seeing. And in that instance, then, how do we accelerate implementation of global and national action plans? So today we are joined by our main speaker, Ryan Haida Mahdi, and later we will have a few panelists joining us to just steer the conversation and see how now we are working in our different spaces to then contribute to the overall 10% reduction in bacterial AMR, as was assented to by our member states against the 2019 baseline that we are very well familiar with through the Graham study. And in this way, our countries have committed to, implementing multi-sectoral national action plans from human, animal, agriculture, aquaculture, if you may look at it that way as well, environment, and just across the board, but specifically with national targets. We appreciate that there's no one size fits all. Whether it's even within the environment sector itself, it cannot be one size fits all, even within one country. So the national targets also have to be different. So we really look forward to listening to our main speaker today, and even as we engage the panelists as they come in. So just to introduce Ms. Ryan Madi, and I hope I'm pronouncing your name well. She is a director of Rational Use of Medicine Directorate at the Federal Ministry of Health, Sudan. Ms. Ryan is a clinical pharmacist by training and holds a master's in public health. She also serves as the AMR National Coordinator and is a public health expert in drug utilization, universal health coverage, and health system strengthening, as well as in advocacy, awareness, and capacity building. So over to you, Ms. Ryan. You have maximum of 20 minutes. Welcome.
Hello, colleagues, our beloved juniors, our esteemed seniors, and all AMR warriors. Uh, Thank you to having me today and give me this opportunity to share with you our 10 years journey in AMR profile in Sudan with all pros and cons. Uh, let's start. Uh, Today we'll talk about introduction to Sudan profile, progress on NAB implementation, NAB1 implementation challenge and way forward, and then we will go to quickly on NAB2 and then our lesson learned. First, let's take like a second to remind ourselves that addressing AMR is very complex, and we must adopt One Health approach in all our activity and all our commitment towards AMR. Sudan uh, to adopt the global action plan when designing and drafting a national action plan. national action plan was drafted and then endorsed on August 2018. Our first objective was improve awareness and understanding towards antimicrobial. During the implementation of the objective one, there was many activities carried on during period between 2018 till now. Weeks carried between 2016 to 2022, forums for healthcare professionals and stakeholders, many community awareness campaign, TV and radio programs also, many student symposium, video clips, 3 songs, and many interesting story like one of 2 interesting activities we're using mobile video cards. Usually we use mobile video cards within the government as for pesticide spraying announcement or vaccination campaign announcement or so on. We used those cards in the middle of the central market to spread AMR messages and songs. Another activity is using large banner in the street, usually used for advertisement like Coca-Cola and Pepsi and telecommunication company. We used all this with our whole existing budget at that time. We asked, and then all media in Sudan now talking about silent killer. What is a silent killer and why? They 3 taps indicating this romycin can kill me or can harm me and so on. There was another interesting tab tailoring antimicrobial program. It's evidence-based behavioral change intervention carried in Jazeera State in a period of 15 months overall, targeting prescribers, pharmacists, and community on the health sector, and also farmer, herders, and vet control. The main goal was to change a behavior and commitment to rational prescribing and rational dispensing. The program was, as I said before, for 15 months. Extension from TAP, and all lesson learned from TAP. We continue our behavioral change campaign, expanded at the state level. We targeted Red Sea, North Kordofan, White Nile, and Khartoum State also, with a massive behavioral change campaign and media campaign for 3 months. When it's come to surveillance and research, there are many activities carried out during the period of 2018, and then unfortunately we failed to establish like a national surveillance system. There was a coordination mechanism. There was a national coordination center. We report to GLASS, and we try to strengthen our lab capacity in the center and the peripheral, but there is no national surveillance system in place. Results from GLASS revealed that there was a high level resistance of gram-negative pathogens, limited therapeutic option compared with gram-positive. Resistance varies from 30 to 90% at resort. Even doctor now using colchicine, which is with high toxicity. Result from GLASS. When it comes to IPC, they point prevalence surveillance carried out in Sudan in 2019, targeting major 8 hospitals in Sudan. The study covers around 1,000 prescriptions. Among them, 90.2% of antimicrobial administered parenteral and around 77% prevalence of antimicrobial use. The average of a number of prescribing antimicrobial per patient was more than half patients received at least 2 antimicrobials. Among them, third generation cephalosporin and metronidazole was the most used together antibiotic. When it's come to indication, 50% of patients were indication for community-acquired pneumonia, and 20% for surgical prophylaxis, and for around 13% were medical prophylaxis. When it's come to quality indicator, antibiotic indication not documented in 50% of the files, antibiotic not compliant to guideline, or even there is no guideline, antibiotic not based on culture in around 77% of the patient. In optimizing use of antimicrobial, there was many documents drafted, like Sudan, updating for Sudan national policy, essential medicine list, standard treatment guidelines with focus with infectious diseases, antimicrobial prescribing policy itself, and then dispensing guidelines, many pilots and program for antimicrobial stewardship in many hospitals. In aligning with aware categorization for WHO, Sudan adopt Sudan aware categorization. It's like attempt to rationalize use of antimicrobial within facilities, do not stick to any protocol or any stewardship program. It's derived from the Essential Medicine List 2020. As you can see, in Sudan, we haven't any reserve antibiotic either in the Essential Medicine List or even registered reserve group. When it comes to Sudan antimicrobial consumption report for glass, around 80% of the antimicrobial imported to Sudan was ampicillins and cephalosporins group. Then we started in January 2023 to update our NAP2 version with the same 5 objectives and 5 years with integrated advocacy plan. We engage agriculture and environment. We try to engage private sector, National Health Insurance Fund, and National Medicine and Poison Board. And we agreed to generate annual plan to be developed based on implementation of the previous year. We started our NAP with gap analysis workshop to identify gap, reason for unimplemented program and why it's not implemented. We targeted our colleagues at malaria program and TB program, one of the most successful program when it's come to indicator M&E and implementation. They help us a lot in identifying our gap, followed by separated M&E and separated gap analysis report. One of the best tool we ever used is a BMB tool, the amazing tool for FAO in evaluating antimicrobial NAP among sectors. We conduct a BMB review on March 2023. After that, costing and budgeting tool, WHO costing and budgeting tool. Unfortunately, on April 2023, armed conflict in Sudan damaged everything and all things. Added to that, a lot of pandemics and many crises. Sudan now, I guess, one of the most, let us see, biggest humanitarian and health crisis in the world. In 2023, coming up to now, 80% of governmental staff working remotely. Among them, all AMR staff in all health sectors, not only in health, work remotely with zero budget. We decided ever to whether to adopt like AMR new strategy, low profile AMR, or to stop, and all all decisions from all sectors was to continue even with a low profile. We keep to meet on regular basis under the World Health Platform and the Technical and Steering Committee. And we provide online training for many groups. And we try to do some WOW activities. The main challenge was to conduct WOW within crisis. But as far as we know, some states still safe and even full of internally displaced persons. So we assist our colleague there to speak in hospital morning meeting in public areas with zero budget. Spoke to pharmacists and prescribers there to raise awareness, and we called it from ourselves. Even some printing material were left over. They used it again, regardless of timing or we also engage antimicrobial use within the package to ensure rational use of medicine within the mobile clinics and all things. Also, after we lost our main natural public health lab in Khartoum, joint activities succeed to upgrade 3 labs in state, and now they are playing major role in bacteriology lab, especially in those states full of population. And due to economic situation, as we know, doctors sent all culture to those different labs. Even reporting now increased in those 3 labs. Also, we conduct a comprehensive analysis to apply like ABC ABC stewardship surveillance pilot within major 3 hospitals in those states. We disseminate this Sudan aware categorization in all facilities. As I said, our plan now, it's called post or reconstruction. Now Khartoum is back, alhamdulillah. Our intervention phase now, comprehensive model for IBC AMS surveillance in selected facilities and engaging AMR again within the programs and revised NAP with new contexts and priorities. Now let me, after I show you what's happening now in Sudan. Now, for everyone used to work with me in AMR, know about my fact-checking framework. It's a table, usually on my desktop, to add all lessons learned whenever mission accomplished throughout the 10 years. We called it myth and truth. It's a table in which we all share ideas and concepts that prove to be incorrect or inaccurate only through experience. First, I apologize for any errors in phrasing, as this added at the last minute. First of all, I would say one of the biggest myths is stakeholder analysis is impractical or theoretically. We heard this a lot within our practice, but it's very effective, highly effective, practical when it's carried comprehensive. It's reveal a lot of hidden area in your plan. For example, milkmen and nurses. Milkmen in Sudan, the man sell milk using a donkey. He added many antimicrobial to the milk, and also the nurse. Nurses are very hidden stakeholder within all activities in all sectors. When we carried this stakeholder analysis, we found out the major player in the AMR is nurse. Also, antimicrobial resistant program operate in isolation as leisure initiative. We used to found antimicrobial program start vertically in the middle of nowhere, but the ideal is to link AMR to every health system effort, including IMCI, BHC, rational use of medicine activities, and addressing within TB, malaria, and HIV. At the end, anti-tuberculosis and anti-malaria and even anti-retroviral is still antimicrobial. Another thing is awareness and education campaign are minimally effective and lack measurable outcome. Whenever I talk to donors that we need to advocate for something or we need to conduct awareness campaign, this was the myth you used to hear. But we, by experience only, one of the most happiest moments to me was when I got back to the third time to the same targeted population, which was the third year student in a faculty of medicine, pharmacy, and nursing in the same college, university college, upon their request to make more and even deeply dive into strategies in antimicrobial resistance. Whereas only the first session was to introduce them to AMR awareness. So think again we have to think in graded assessment and impact of awareness campaign to maximize the effort and to maximize a benefit from awareness campaign. Another thing is the private sector. Usually we heard that private sector is our enemy. You can go to step, we can't go anywhere without private sector. Actually, in Sudan, we have a success story with engaging Hikma company, which is a big importer of IV antimicrobial. They join us because they do not want to lose their effectiveness of their valuable medicine, as they said. Now, even they committed to fund antimicrobial stewardship program within selected 3 hospitals in Khartoum. And now they are a part of our technical committee as well. So engage private sector as much as you can. Another thing is One Health approach. Never ever One Health approach is like doubling the work. It's your main coordination mechanism. Another lesson learned is that when we talk AMR or public health in general, you might encounter some brilliant candidates, methodologically clear, methodologically active in their work, dressing elegantly, speak well English language, fancy dresses, but passion and willingness is the key. It remains the most crucial factor for sustainability, I guess. One of my lovely stories is that my beloved volunteer from the campaigns in the state they still now doing like advocacy and doing awareness campaign online and everywhere in AMR itself. Another thing is that coalition building. When we call coalition building, they think that also planning tool and planning planning terminology. No, coalition building is very, very essential, and pooling knowledge and resources is very, very, very comprehensive way to go forward. Promotion also, we hear a lot about promotion. That is a made all many point fingers at promotion as main cause for antimicrobial resistance. But in Sudan, we have like one of the biggest private hospitals in Sudan called Fidel Hospital. They succeeded in streamline promotion and develop antimicrobial stewardship program within their context and challenges and their all assumptions. Last but not least is the program success is exclusively depend on fund. Okay, fund is important and it's a main determinant, but sometimes there is money, but ideas and plan either unrealistic or unimplementable. We have to think about what is the truth and what is myth in every plan, in every activity we use to carry. And that's all. Thank you.
Thank you so much, Ms. Ran Marty. Thank you so much for an excellent presentation I love what you just said at the end. You could have so much money actually, but it's not practical to conduct what you want to conduct. If it doesn't work for your context, if it will not be sustainable, if it does not, bring about the ownership from the target population, then, you might as well just pack your bags and go home. Facts checking matrix framework, create your own and share with others. You couldn't have put it better when it comes to, moving from paper to action, as we are saying that as a world, we want to have something to report in 2030 or 2029 at the UNGA, how much progress we've done towards 2030. And even just starting next year when Nigeria is hosting the next high-level ministerial conference. So I want to welcome any questions, comments for the next 10 minutes or so. And when I look at the chat currently, we seem not to have any as they're coming in. Oh, sorry. Yes, I have seen one. Then maybe I will put mine in the parking lot and just ask from Allah Afdal, can you describe more in detail your national structure for the governance of your national action plan? And if there are any if there's any report, okay, if there's been any report, I believe, published on the implementation. Ryan, over to you.
National structure for antimicrobial resistance consists of a higher committee, consists of around 57 members from all sectors, and then it's come the technical committee headed by the Undersecretary, Federal Ministry of Health, and representation from the other three ministers, Ministry of Environment and Agriculture and the Animal Health, and technical bodies. It consists of 15 members. They representing their entities and running the antimicrobial activities among their entities. Report, I can share with you some reports, inshallah. I will do regarding implementation. It's not for the NAP, overall NAP, separate report for awareness and other for IBC and so on.
Okay. All right, thank you. I hope that's been well answered. I believe it has. Then I'll quickly, because of time, Collins Himabala thanks you for the presentation and asks, or rather he wants to know if there are any IPC activities that have been done. I think you did mention them, more so on integration of these activities into the One Health approach.
There are many activities done. For example, the wash activities carried in the animal sector and the human sector as well. Some activities regarding food safety with coordination with the lab of the lab. Many activities. It's short scale, but it's existed.
Okay. Thank you. Maybe you could just, I don't know who's controlling the slides. Is it you, Dr. Mahdi? Maybe you could just go also to the IPC slide that was there. I think it also spoke quite a bit into, but if we cannot get it, it's fine. Okay. Okay, it's fine. No worries. And I believe the presentation will also be shared with the participants and the clarifications can be then made even better. So I'll move on to the next question. Since we have about 5 minutes into the sorry, I got distracted there. We have about 5 minutes into the Q&A. So Irene wants to know if you can talk more about the milkmen. Which medicines do they use, and what plan do you have to control this? I like the idea of including nurses in this fight against the behavior. Over to you, Marty.
Milkman is the strongest man ever and strongest to tackle. He added streptomycin and penicillin, used for human. They add it to the milk and then sell the milk even with 40 degrees and all the day. The milk will never spoil. So when they took like samples of the milk, they found streptomycin and ampicillin. I guess gentamicin also. To tackling milkman, simple strategy is to talk to the community there.
Ryan, I think we're losing you.
We talk to the community. Simply, we talk to the community a lot. That will kill your children and will harm yourself. And we use all existing data towards public to make sure that they will never ever buy milk again from that milkman. That was the strategy.
Oh, okay. Right. It's good to hear that such tactics do work. I really wonder how practical it is maybe in other areas when they're told not to buy milk from that particular person. Yeah. Okay. I know there are other questions in the chat, but I just want to give Ridwan, a chance to speak. The hand has been up for a while, so you have been enabled. Kindly go ahead.
Okay, thank you, Tracy, and thank you very much for the presenter. I so much enjoyed the presentation as she was making the submissions, and I'm just reflecting on what is actually happening in Nigeria. I really like the fact sheets, the myth versus the truth, reality of what is implementable and what works for the countries. So congratulations for actually sitting down to really understand what works for you, and not just in the effort to align with the global strategies, but we also need to really understand what works for us based on the available resources we have. So I will be very glad if you can share the tools you use in conducting this feasibility assessment, and of course, even the assessing the National Action Plan 1.1. It will help a lot in also trying to gather information about Nigeria's effort. We've been doing a lot of activities, so it is also important for us to be able to use standardized tools to assess ourselves again. Maybe for the midterm, because we are already implementing the second National Action Plan. So I'll be very glad if you can share those tools that you use, the feasibility, especially the feasibility assessment tool that you use to come up with the myth and the truth, the realities with regards to the implementation of your interventions in Sudan. And congratulations for all that you do. Thank you, and over.
Thank you, Ridwan.
Thank you very much. Regarding the tool, gap analysis or root cause analysis was local generated methodology. I can share with you the steps and all the necessary to do. But I strongly recommend BMB tool. FAO BMB tool is a very, very, very comprehensive and elaborating many hidden areas, as I said before. I will share with you all the documents, inshallah.
Thank you so much.
Thank you. Yes, and definitely the tools will be shared, I believe, even with a presentation. And I echo Ridwan's sentiments. This is actually really good. I think personally, it's the first I've seen, trying to just depict the difference between the myths and the facts around our implementation. Yamanya, I stand guided by you. Should Yapo come in, Kiame, or
Yes, we can take one
his
last
hand is up?
question before we go to the panel discussion.
All right. Okay. Yapo, kindly go ahead. You're enabled. And if you're speaking, you are on mute. Also, to our French speakers, kindly note that you can actually ask your question in French. It will be translated. Thanks.
Tracy, someone asked about engagement of the university student.
Okay,
I
Ryan,
want
yes, we
to,
put it
yes,
down. Yeah, please go ahead. Answer.
yes, we made like a society. We called it, actually, we called it rational use of medicine society. We engage them in one platform. All of them are students, medical student, and veterinarian, and laboratory student, and all students. We give them a regular basis with all updates regarding AMR situation globally, regionally, and within the country in one platform just through email, and they do their own activities within their settings. They invite us. They used to invite us to come there and help them within their activities. And at the end, now they called AMR. I guess it's called AMR committee
Ryan,
or AMR committee.
Ryan, just hold on as we try to mute Yapo. Just 1 minute. There's background noise. Apologies. Yamanya, kindly mute Yapo. Thank you. Okay, apologies, Ryan. I'll give you a chance to start, once again, in responding to the question on youth. There was a lot of background noise.
Okay, as I
Please go ahead.
said,
Yeah.
we have like a community society called the Rational Use of Medicine Society, targeted for medical students and other students for all undergraduate and postgraduate, freshly graduate. We engage them together in WhatsApp group and group email, and we send all necessary documents on regular basis, all spread messages and the themes for the campaign or whatever, and they do their awareness or education. They prepare themselves for doing their campaign within their setting. We join them to help sometimes. Progressively, now they do their activities alone, and even they report to other international, I guess, community or something. It's really success stories for undergraduate student engagement, and now they talk MR language like even public health experts within the field.
Thank you so much, Brian, for honestly really a really engaging presentation. A lot has been done in Sudan, in spite of the challenges that you've mentioned. And I think I can speak for everyone on screen right now. We're happy to see Khartoum is back. We're happy Sudan is back, or, coming back, and just really impressed by the resilience behind it. Even as we, in the quote unquote non-conflict zones, may complain about this and that. but I dare say maybe we should be a bit embarrassed when we complain, especially when we see the progress, the resilience, the successes that are actually recorded even in the background of such conflict. So thank you so much, Ryan. But please don't go, since you know you're also part of our panel. I'll just quickly introduce the panelists that are with us. And sorry, I had to put off my video. I wasn't sure that it was my internet that was unstable. I could not hear quite well. So forgive me for this. I will still put it off as I introduce our panelists. So Ryan, we've already introduced her, and she's made, or rather she's taken us through this presentation. So now allow me to introduce, we have Johannes Muroa. I hope it's not Johannes. If it is, I apologize. Is the AMR focal person for the Ministry of Water and Sanitation, Malawi. He is responsible for coordinating AMR activities in the environment sector. He facilitates development of standard operating procedures and ensures that quality control and quality assurance procedures are adhered to, as he even coordinates data generation through active and passive surveillance in addition to reporting. Then we also have Tinashe Hodobo. Tinashe's profile is quite long, so I will make it into half. We have worked with Tinashe before, and many of you may know him already as a member of the One Health Secretariat within the government of Zimbabwe, focused on coordinating activities related to AMR. His role involves fostering partnerships both nationally and internationally while implementing the AMR NAP. He facilitates the AMR core group's activities and ensures effective communication and information sharing among various stakeholders and sectors. Then we also have, sorry, I think the others have not joined us, so I will leave it
Dr.
at
Seba is
that.
in.
Oh, Dr. Saber, I cannot see. Is he or she part of, are they activated
She
onto,
is.
because I cannot see.
She
Okay,
is.
all right. Apologies. So allow me to introduce Dr. Saber Manyango. She is a pharmacist working for the Division of Pharmaceutical Services, Ministry of Health, Liberia, and is also the focal point in the country. Some of her roles include coordinating MR activities nationally and internationally, conducting the monthly technical working group meetings with stakeholders, as well as collating, cleaning, and submitting AMR data to feed into the class, while also advocating with partners for support to implement the country's AMR strategic plan. So I want to welcome the team once again, and I will quickly then dive into the questions. I will maybe start with Johannes. Johannes, we have had an excellent presentation by our colleague from Sudan. And I don't know, when you actually look back to that, and even just from your own experience, how can we actually go about making the next global action plan more actionable? That is, if you look at it from what are the top three priorities or shifts that you'd like to see in the updated global action plan to make it more practical and aligned with the real world needs we've just seen, to ensure that it's actually a pragmatic plan and relevant to each and every country. You're on mute. Are you able to unmute, or Yamanya, could you look into that? Apologies. As you all know, this is normal with anything that involves IT.
He should be able to unmute. I can't unmute him from my end.
Okay. Johannes, can we give you one more minute? Otherwise, then we could move to the next question as we allow you to perhaps log in and come back. I mean, log out rather, and then come back. Okay. So as we allow Johannes to sort out the technical issue, I think I want to go to, yeah, I can see not yet. So Cyber, maybe I can come to you then and look at your question from looking back from where we've come from and then moving forward. As a quadrupetite begins reviewing the Global Action Plan on AMR, from your experience, what have been the most significant lessons from its implementation over the past decade in your country or in your region from your experience?
Thank you, Dr. Yamaya, for the opportunity given me to be a part of this webinar and this important discussion surrounding antimicrobial resistance. Liberia have had tremendous impact from the implementation of the National Action Plan on Antimicrobial Resistance. We have learned significant lessons from the implementation over the past decades. For instance, the establishment of the One Health Coordination Platform, a multi-sectoral approach to tackling antimicrobial resistance has been effective. This has improved coordination among sectors that have AMR activities being implemented in their sectors. We have a well-established AMR technical working group with well-defined times of reference. And this technical working group has been leading the coordination and collaboration of the antimicrobial resistance National Action Plan implementation. The AMR Technical Working Group have its regular Monday meeting on the third Wednesday of each month. So this is a lesson that we have learned from the implementation of the National Action Plan, that only with this One Health Coordination platform, we are able to achieve our goals in combating antimicrobial resistance in Liberia. We have coordinated efforts, and through this platform, we have been able to discuss challenges faced by various sectors and also design strategies to address these challenges. The implementation of the National Action Plan has also encouraged us to integrate our policies based on existing policies from various sectors. We have developed an integrated AMR surveillance strategy, which is to be implemented, and that will take effect from the Health Security Plan and World Bank support in this phase of the implementation of the Health Security Project. We have developed the integrated AMR surveillance strategy that has SOPs and procedures from various sectors, and we have identified priority pathogens and priority specimen based on the GLASS priority pathogens and specimens. So this National Action Plan implementation has created a space also for us to improve partnership. And these partners we have been collaborating with have been giving us technical and financial support in the implementation of the National Action Plan of Liberia. Some of the partners are WHO, FAO, US CDC, and the Africa CDC. The implementation of the National Action Plan have also encouraged us to improve capacity building of healthcare providers and also those that are conducting surveillance. Moving forward.
Thank you.
Hello?
Yes, Yes, kindly wrap in the next minute or so. Thank you, Dr. Seba.
Yes. I was just looking at moving forward. And moving forward, we want to promote the antimicrobial stewardship program, strengthen surveillance, because these are areas of focus and where we identify major challenges in the implementation of the National Action Plan. So we would like to encourage our partners to help support us in promoting the stewardship
Um, Apologies. I think Dr. Saiba is experiencing internet challenges, but thanks, Dr. Saiba. Unfortunately, we lost you as you were just winding up, but thank God it's as you were just winding up. And thank you for giving us a comprehensive summary of actually, from the space in Liberia, the significant lessons that have been experienced over the past decade as you are trying to implement GAP. And actually, from what you said, I think we can almost confidently say, but no pressure, that Liberia will be amongst those that come 2029, as we're going back into the UNGA high-level meeting, can proudly report to be one of the countries that's contributing to at least 80% of, or rather that the 80% of the countries can test resistance in all bacteria and perhaps fungal pathogens that are included in the glass system by 2030. So congrats on that. And we also wish you the best in your way forward with the stewardship and surveillance as you began telling us as you were winding up. So, having come from that and what we've just had from Dr. Saber, maybe I could then pick on Dr. Tinashe. And no worries, Dr. Saber, that's okay. For the poor connectivity, I think that comes with the environment at times. But I want to pick up from where you just left us and then pick on Dr. Tinashe when it comes to strengthening our systems for sustainable impact, what we've had in the case of Liberia, how, from where you sit, what investments or system level changes then are most urgently needed to ensure AMR interventions are integrated into routine health and veterinary systems rather than remaining as siloed efforts? As we've heard from Liberia, one of their success stories is actually leveraging on the surveillance that they're doing and reporting on glass to actually bring about, coordination of partners and working with partners to be able to create a more sustainable and impactful AMR agenda within their country. So in your experience, Dr. Tinashe, what investments or system level changes are most urgently needed to ensure that AMR interventions are integrated into routine health and veterinary systems rather than remaining as siloed efforts?
Thank you. Thank you so much, Dr. Tracy. Maybe if you can just confirm if you can hear me clearly.
Loud and clear. Kindly continue.
Okay, thank you. Yeah, so firstly, I just want to appreciate the presentation by Dr. Ryan. I think it really set the stage, giving us a lot of insights into the efforts in Sudan, and under the most extremely difficult conditions, they've achieved quite a lot, and that is greatly appreciated. I think getting into the question that you have raised, one of the most critical issues, which also came out from the presentation from Dr. Ryan and also the previous speaker, the colleague from Liberia. There's the issue of institutional integration and to look at governance issues, which means, in order for us to have sustainable gains and sustainable impact, there's a need for a governance system, and it has to be a One Health governance system. And here we are looking at key sectors being part of that One Health governance sector. We are looking at the human health, animal health and environment, the food and agriculture sector. And you need the partners to be on board. You need the CSOs as a civil society organization. And you also need to have the gender and equity lens also as part of that, because we are talking about sustaining gains and impact. The other issue on governance that we need to pay close attention to is the issue that we need AMR focal points, maybe at a national level. And in most cases, I think from my own background, from our experience, I think we've had structures at national level, which is a plus. But remember, for us to make some impact, we need to have the certain levels also being considered, the provincial level, the district level, and we need to get to the communities. I think this issue of institutional integration and governance and the One Health approach is absolutely critical in terms of sustainable gains in our fight against antimicrobial resistance. Another issue that I feel is a critical point is the issue of sustainable financing mechanisms. Once you know exactly what you want to do, you have structures, and of course, the assumption that I'm making that there's a national action plan which the governance system will be acting upon. But you need these sustainable financing mechanisms. From our knowledge and recent experience, we've seen, the downside of donor dependency, and having donor-driven, financing mechanisms. One day the donors might pick and go, and you might be left without any means for continuing with activities or for sustaining activities. So there's a need to have domestic resource mobilization. On this point, we are looking at maybe having budget lines that are specific and that they are ring-fenced and they are targeting, activities and interventions around the AMR issue. And on sustainable financing, I think there's also a need broadly to look at public-private partnerships also. I think it goes into sustainable financing, and that is the kind of investments that we should be looking at, which are homegrown. The other issue is to have an integrated surveillance system where we are looking at antimicrobial resistance and antimicrobial use, both of them. Here, the information infrastructure, which is integrated, can be very, very helpful because you get to have a holistic picture and also to come up with ways of doing things and ways of intervening that is guided by evidence. So with information systems that are integrated and with interoperable systems which are talking to each other across sectors, it's a huge benefit because we address the complexity around the AMR, which makes it a One Health issue. So if you have information that is coming from different streams and converging, you are empowered to make sustainable decisions that are evidence driven. And still on the information systems, I think for some countries, they already have existing disease information systems. So it will be just a matter of maybe adding particular modules to those information systems, depending on the country situation. So it might not be about reinventing the wheel, but just integrating AMR surveillance into pre-existing disease surveillance system. There is another critical issue on workforce development. I think I am a strong advocate of pre-service training, where professionals need to be trained prior to getting into the workforce, so that they are aware about antimicrobial resistance and they are well grounded in terms of the principles of antimicrobial stewardship. And here on workforce development, we also need to consider issues like continuous professional development. As you know, that there are always new things that are coming up, and the professionals have to be abreast with the latest knowledge and the cutting edge innovations within this particular sphere. There is also the aspect of having a strong regulatory framework. I think that is another issue. I think it's the fifth issue that I've been spoken about. And in this case, there's a need for an inspectorate that has the capacity to cover the entire jurisdiction of the country. And from the veterinary perspective, I think there's also need in certain circumstances to relook and to rethink about the classification of medication, because there are some medicines that are found over the counter, and maybe we might need to have them as prescription medication, guided by, the WHO list of critically important antimicrobials. And I know that the World Organization for Animal Health, WOA, is also a critically important antimicrobials. There is an entire classification system, and we can be guided by such documents that can help us to sit again and to rethink what classification we can give to the antimicrobials so that we preserve their effectiveness whenever we need to use them. Another point that I would like to touch, and I'm just about to round up, is the issue of community engagement and stakeholder engagement. So I think, Dr. Tracy, I might have overshoot the time that I'm supposed to talk and also to share. But I think sustainable, investment and sustainable impact can also be achieved by going to the grassroots and customizing our interactions with stakeholders according to the stakeholders type that we have. I think for now, I've said quite a lot. I think that those are some of the key points that need to be considered within the context of the question that you have raised, hoping that, whatever gains we make, we are able to sustain them. Over to you, Doctor. Thank you for the opportunity.
Thank you so much, Dr. Tinashe. I know you are quite passionate about the topic, and honestly, you've brought out quite a number of points, quite pertinent points, as you said, that have just fed into the question and also just enriching the previous feedback. You've brought out, as you've said in the very end, grassroots engagement. You've brought out strong regulatory framework, perhaps classification of medicines in animal health, but also basing it, on the WHO human health antimicrobials, because we're talking of strengthening the systems for sustainable impact. But more important is use existing rather than reinventing, not just on surveillance, but just all around, even when it comes to what you mentioned on financing, for instance. If we're looking at financing mechanisms, where can we leverage, where can we plug in rather than reinvent the wheel? So thank you so much. And I think then I think that gives us a perfect segue. And I believe I can see now Johannes is unmuted, so that we can come back to, I'll be fair to you, Johannes, and I'll not ask you a foreign question. I'll just come back to the same question that I had posed earlier, and just try and get your opinion on if you've had at least the last two panelists on their feedback. So based on that now, and as we're saying that we want to make the next global action plan on AMR more pragmatic, then what are the top three priorities or shifts would you like to see in the updated global action plan so that it's as practical as possible and aligned with the real world needs to ensure that it's relevant to each and every country that we have? Johannes, over to you. I hope you can speak now.
Tracy, looks like his audio is still problematic.
Okay, shame. All right, then I think maybe I want to move to the last question then, and pose it to cyber, but not just cyber. If the other panelists want to come in on this one, kindly come in, and then we can take on some few questions from the audience and wrap up. So we have had from Dr. Saiba an excellent presentation. Sorry, Ryan, I'm sorry. An excellent presentation. Then we've had from the panelists here excellent input. So how do we measure what matters? How should progress on AMR be tracked in the next phase of the Global Action Plan? As much as Johannes is having issues with his audio, but I think we can already say that we've heard from the panelists and really what needs to move from paper to practice and make it more actionable. So as we're making it more actionable, then how should this progress on AMR be tracked in the next phase of the Global Action Plan? And are the current monitoring tools effective? Where, for instance, we do have the joint external evaluation on the one hand. We then have the Global Action Plan on the other, with two different accountability structures, if one may look at like that. And we've seen from Ryan, who has actually really encouraged us to use the PMP from FAO. So we have all these tools in place. Are they all fit for our different countries and regions? Or should we say that we must contextualize and each country should look at what works best for them? And do we need new ones? If yes, how do we go about bringing in these new ones? Maybe we could start with Saber. Dr. Saber?
Yes, thank you, Dr. Namaya. I hope I have your name correctly. Yes, so if progress should be tracked in the next phase of the Global Action Plan, then I think what could be done is to harmonize the indicators of all of these plans, like the JEE, and the PVS, and all these monitoring tools, we could harmonize the indicators that will help to reduce the duplication or impact of duplication of the activities. So we can create or align the tools to have one monitoring framework that will help us and also be able to base the evaluation on based on country context. So some countries, like for the global action plan indicators, it was kind of done broadly and did not take into consideration lower to middle income countries. So all of the indicators on the global action plan are just fixed broadly. So we will need a tool that will contextualize the country setting, and that will be easy to at least achieve what we need in the monitoring phase. So this is my input, that we can harmonize the indicators of the various monitoring tools.
Thank you, Dr. Seba. I think that's excellent. We need to look at all these tools, at least the accredited ones that we have out there, and perhaps harmonize. And it's encouraging to hear that because, of course, as the quadripartite is calling upon us to feed into the consultations that are going into updating the Global Action Plan, there's also the M&D framework that's going in tandem, hand in hand, being looked into. And we know of a few countries that already have the M&D framework as they continue to update their national action plans. And so this is something that we really hope our countries will take on. I don't know whether there's any other panelist that wants to come with a response to that question. Otherwise, we could go into looking for any questions from the audience. Dr. Tinashe, Ms. Ryan. Have I left out anyone?
Thank you.
Yeah.
Oh, through you, Tracy. Thanks so much. Yeah, I just wanted to point out, maybe to add to what has been said, because if we are looking in the context of monitoring tools for the implementation of our national action plan, I think at the country level, the obvious tool is if you have an M&E framework that has been developed together with the National Action Plan for the specific interventions that you have, you can base your tracking progress at country level based on that. The FAO PMP tool is quite useful. I've had an opportunity to be in an exercise where it was being implemented and being used. I think it's a powerful tool, but the limitation is that there's the bias towards the food and agriculture sector. Of course, there are linkages that you find within the tool to the other sectors, human health and environment. But I think there is a need just to broaden, and I think it is just an issue of mandates and a discussion within the quadripartite arrangement. There are other tools also when you look at, the surveillance base for antimicrobial resistance is the laboratories themselves. There's a FAO Atlas tool for the food and agriculture sector, but essentially the features of the tool can be applied to any microbiology laboratory to check the capacity for antimicrobial resistance. And of course, when we are looking at other indirect ways of basing the performance of implementation of our NAP, there's the WHO tracks tool, and of course the surveillance system tools also is a reflection of the capacity of a country to generate data. There's INFARM from FAO, there's also GLASS from WHO. There are a couple of them, and someone mentioned that the JEE evaluation is a critical tool for looking for introspection. So I just wanted to add that to what has already been contributed. Over to you, Dr. Tracy.
Thanks, Tinashe. Yes, indeed, we have all those tools. That's true. And perhaps if we take on what has just come from your response and Dr. Sabas as well, then surely we should be well into achieving the commitment that our member states ascended to regarding 95% of our countries now feeding and providing quality feedback into the tracks, yeah, while even as we're looking at the other available platforms. So thank you so much, dear panelists. This has been quite interactive and very useful. I just want to segue into Q&A. And I can already see a question, and perhaps it was answered, but just quickly from Ibrahim Akoma, where he says veterinary medicines, and maybe Tinasha, this is on you again, but I invite any panelists to respond. Veterinary medicine is challenged by the use of antibiograms in rural areas. Animals are often found in the bush. What can be done to practice precision medicine in the animal health sector?
Thank you, Dr. Tracy. Yeah, I think Ibrahim has got a very important point, and from his question, I get the sense that he's saying that to have treatment that is guided by the laboratory becomes a challenge in the rural areas, in remote places where you don't have access to laboratory services. And indeed, I think this is a challenge in some circumstances and most circumstances that we find ourselves within the low to medium income countries. I think it's just an issue of capacity. That's the first comment that I give, that, within the national plan, there is a need for deliberate intervention that looks at building the capacity for laboratory testing, so that, for patient care and also for guided treatment, you need to be guided by the results that come from the lab, and the lab has to be available for you to do that. That is the first comment and the first point in terms of that question. Then the other angle to that is the consultation with the trained personnel. There are veterinarians, there are also para-veterinarians, there are extension staff that are trained in terms of understanding animal diseases, clinical diagnosis of those diseases, and also in terms of understanding the medicines that are appropriate for certain disease conditions or infectious conditions. So it's a layer of protection that you put when you have professionals that you consult, and there's what comes naturally out of that is you increase the chances of effective treatment, also in the prudent use. But in the long term, I think there's a need for a plan for strengthening the laboratory services within the sector. I think for now, this is what I can give as a response. It's an issue that might require a longer discussion than the time that we have here allows. But I hope that will be useful feedback to Ibrahim. Over to you, Dr. Tracy.
Thanks, Doc. So I know you've provided a great answer, but so I want to poke a little bit more and ask you, when I look at the political declaration, as a region, we were really hoping that we would get, that the target that had been quoted during the high level meeting in 2022 of 30% reduction in vet medicine use, but then it was watered down in the political declaration to simply read meaningfully reduce the quantity of antimicrobials that are used globally within our agri-food systems. Do you think, in your own opinion, and this I hope is not being recorded, do you think, as a globe, come the next high level meeting, we will actually have a baseline that we can speak of in the animal use antimicrobial part and actually say that this is a baseline and now we're working towards, let's just say, 30% reduction, based even on the response that you just gave to Ibrahima?
Thank you, Dr. Tracy. I think you touched on what I was going to give as a response first. That to reduce, you need to start from somewhere, and you
Yeah.
can't start to reduce unless you know where you are. So I think there's that issue about the baseline is critical. So we need,
Yeah.
in our context, in our African context, to appreciate our status, where we are now, before we start to talk about reducing. We might be, in some circumstances, I think there are actually challenges of access. Some don't even have access to the antibiotics and the antimicrobials, and they are life saving for the animals and on welfare grounds, and also, where they are needed and prudently used, they might not be available. So the baseline will definitely be needed. And in terms of whether we are going to be there by 2029, if I'm not wrong, we are moving towards that, I believe. Why am I saying that? In selected African countries, which will turn out maybe to be more as we get into the future, there's been some pilot activities related to collecting data on antimicrobial use and antimicrobial consumption. But at best, most countries that have regulatory systems for medicines, they can give at least some data on antimicrobial consumption, which is the import and export data. And that is something which is a low hanging fruit. It is somewhere that we can start from. But in terms of what actually goes into the animals, we have to come up with better systems, better mechanisms of getting to that. But for now, and in most regions of the world, we are stuck with the estimates of the consumption. But slow but sure, I'm sure we'll be able to get there. Over to you.
Okay. Thank you. Thank you so much. Yeah, I think let's start with what we have. We will get there. And that's a low-hanging fruit indeed, the consumption data. So 3 minutes to time. And I just want to express on behalf of React Africa our sincere gratitude, not just to the panelists, Dr. Seba, Dr. Tinashe, Johannes, despite your challenges, welcome and thank you. And really sorry about that. And especially to Ms. Ryan, who actually really laid an excellent platform and just showing us, we can still do this. In spite of any challenges we may have, we can do it. We can be resilient. And as they say, tough times do not last forever. It is the tough ones that actually outlast the tough times. So, ladies and gentlemen, our audience that has stuck through this 1.5 hours, I want to thank you again and also thank you to the interpreter. Thank you, Amanya, for coordination and Olen and team in the background. And I just want to encourage you to keep looking out for this webinar series, which will be conducted every fourth Tuesday of the month. So similarly, we will have one on the 22nd of July, same time at 1600 hours or 4 p.m. Central African time. And the next webinar, we hope to have very engaging panelists and speaker on strengthening One Health approach and multisectoral collaboration for AMR control. And in this one, we really hope that we'll also get to bring in our counterparts from the environment sector and really see and hear what they're up to, what challenges they could be facing, how are they, addressing them, and so that we truly can say that we have an impactful, multi-sectoral, and One Health coordination. So thank you so much to everyone, and do have a good evening, good night, good afternoon, wherever you may be. Thank you, and bye-bye.